Let's talk about informed consent. We will be looking at the important topics of informed consent, substituted judgment standard, life-prolonging medical interventions, medical futility, and palliative sedation. These topics are related to ethical decision-making. Perhaps the most important theme throughout these topics as related to ethics is this: what would the patient want? The patient's wishes, desires, and decisions are the most important thing. Involving patients in making their own medical decisions is imperative. The heart and core of medical ethics is found in informed consent. This refers to how decisions are made, who makes them, and what standards are followed. At all times, the most important objective is for the patient or delegated decision maker be informed in the healthcare decisions. It is ethically impossible to give consent to something you do not understand. Informed consent can only be given by a competent adult with demonstrable decision-making capacity. The patient should always take first place in this process unless they are unable and deemed incompetent. The key word here is informed, which implies complete understanding. Often, in the hurry-up moment of decisions needing to be made and forms that need to be signed, administration and medical staff hurry through an explanation and ask for a signature. Often, the patient is unable to ask questions or clarify or demonstrate understanding and will simply just sign forms as requested. This is not an example of informed consent, and many a lawsuit has been brought against institutions where patients or families prevailed against them. Informed consent is important. Chaplains are experts in communication and should work diligently to help patients and families reach the state of understanding. This means understanding their needs, the diagnosis, the options, and especially decisions that impact their spiritual health, peace, and comfort. If a patient is not able to give informed consent, there is a process to determine who will do so on their behalf. This is called the substituted judgment standard. This determines the legal guardian or the designated healthcare agent, if there is one. The surrogate decision maker becomes responsible for decisions on behalf of the patient based on what they understand the patient would desire. The surrogate's task is to reconstruct what the patient would have wanted in the circumstances at hand if the patient had decision-making capacity. How does the surrogate know what the patient would desire? Hopefully by personal awareness of a patient's stated wishes, knowledge of the patient's religious or moral views, understanding the prognosis of a given treatment, risk of side effects, the severity of treatment, the wishes of family and friends, and others. So imagine a 98-year-old dying woman who codes with a heart attack. Should CPR be administered? Is a broken sternum worth keeping her alive for a little while longer? Such decisions can be difficult to make. As chaplains, it is likely that you will help guide patients, their families, and designated surrogates through the difficult maze of decision-making for a variety of issues. CPR, mechanical ventilation, dialysis, and artificial hydration and nutrition can certainly prolong life, but at what cost to quality of life? Is the treatment worth it, and would the patient want it? Very often, loving family members will disagree over what to do, and you are tasked with helping them make an informed decision that simply must be made, while helping them find peace in the process. But what happens when a patient is in such a state as to be unable to make their own decisions? What if they are not mentally competent, comatose, or have a number of reasons why they cannot make decisions for themselves? This is where the substituted judgment standard comes in. Substituted judgment is centered on respect for the precedent set by the patient for their own autonomy in making decisions. If they are unable to make decisions, then preference must be given to their stated wishes or based on prioritizing their stated preferences in the past. Nobody should ever be able to override or trump a person's critical interests, stated wishes, values, and preferences that they have communicated and lived by their whole life up to this moment. Even when unable to make decisions, the patient should always retain control of the decisions, even if they are delegated decisions. But this can be tricky business and serves as an illustration of the importance of advanced care directives. These give the patient a clear voice on important decisions if and when they cannot make them. For this reason, especially if no advanced directives are in place, there is a legal standard for the hierarchy of decision-making under the substituted judgment standard. As chaplains, it is important that you become very familiar with the laws and advanced care directives in your state. These differ from state to state. In general, the hierarchy describing the people who may make decisions for a patient in order of importance are legal guardian, if one has been designated. If not, healthcare agent, if there is one. If not, the spouse becomes the decision maker. If no spouse, then adult children are typically asked for decisions. If none, or they are unable to decide, then any living sibling would be asked. If none, are there any other relatives? If not, what about friends? As chaplains, it is likely that you will help guide patients, their families, and designated surrogates through the difficult maze of decisions, making for a variety of issues. In a clinical setting, chaplains are expected to become familiar with medical procedures and the associated jargon. But this is true no matter what setting you are in. Like all settings, for example, first responders have their own lingo you should translate for people under your care. CPR is cardiopulmonary resuscitation, which may be performed if a person stops breathing. Mechanical ventilation is a machine that breathes for the person, keeping them physically alive. A tube is inserted down the throat through a hole cut in the throat called a tracheotomy. This requires both sedation and pain management. The person will not be able to speak. How might its use be ethical, and when might it be unethical? Artificial hydration and nutrition is used when a patient is unable to swallow or eat due to medical problems. Nutrition can be administered through a tube inserted through the nose and down into the stomach, or fluid replacement might be administered through an IV. Dialysis is a significant intervention requiring a shunt to be inserted surgically. The person must undergo dialysis every 2 or 3 days by being connected to a machine for hours at a time. While this mechanical kidney does clean their blood for them, they are forced to embrace a new lifestyle of constant visits to the dialysis center. In most cases, if dialysis is chosen, the patient will never be able to stop it, with few exceptions. When you consider these examples, it should become obvious how important a patient's wishes are. What are their goals and their values? Would they want these procedures implemented, keeping them alive, but to what purpose? As a chaplain, your job is spiritual care through effective communication. You must learn to navigate the minefield of emotions and diverse opinions of family and staff alike. How can you help decision makers make decisions based on what the patient would want them to do, even if they are stressed out by the decision? How can you bring the family together in acceptance of such decisions? Finally, a word on palliative sedation. This is a procedure designed to deal with unmanageable, hard-to-control symptoms at the end of life. The intent is not to cause death, but to relieve suffering, and is used when a patient is already close to death. Even here, there is ethical controversy. Elimination of pain often causes a comatose response, and so palliative sedation is ethically defensible when used, one, after careful interdisciplinary evaluation and treatment of the patient, and two, when palliative treatments that are not intended to affect consciousness have failed, or in the judgment of the clinician are very likely to fail. Three, where its use is not expected to shorten the patient's life to death. And four, only for the actual or expected duration of symptoms caused by the patient being terminally ill and near the end of life. The suffering is unmanageable to treatment, and the intent of the sedation is to control the patient's suffering and not to hasten the patient's death. Always remember that palliative sedation is used to lessen pain and symptoms of a condition and its treatment that are difficult to control otherwise. Finally, your place as a chaplain is to walk alongside patients, their family members, and their friends as they make these difficult and important decisions. May they find clarity, comfort, and peace as you offer them the sacred presence of God.